Multiple choice questions. 1.1. Which of the following best describes what is meant by the term shared decision making? Option A, allowing the patient to make decisions about his or her care. Option B, asking for help when needed. Option C, making decisions with the wider clinical team. Option D, patient centered evidence based medicine. Option E, sharing decision making with the patient, relatives, clinical team, guidelines, and decision aids. Answer is option E. Shared decision making refers to the fact that clinical reasoning does not necessarily take place solely within a clinician's head. Good decision making is often shared with patients, relatives, and carers within teams and by using guidelines, clinical prediction rules, and other decision aids. Integral to all of this is the ability to engage in optimal decision making behaviors involving the patient and or carers in the diagnostic and management process, listening to others, following evidence based guidelines, asking for help when needed, and using clear communication, especially when handing over care. 1.2. Which of the following best describes what is meant by the term metacognitive knowledge? A. An awareness of and an ability to think about one's own thinking. B. An understanding of how things fit together. C. An understanding of how to do something, what techniques to use. D. The tendency to engage in deliberate practice. E. The tendency to look for evidence, weigh things up, and be aware of context. The answer is A. Metacognition literally means thinking about thinking, knowing about knowing, and being aware of one's awareness. Metacognitive knowledge is about being aware of one's own cognitive processes and is a key ingredient for successful learning and the development of expertise. 1.3. When using a clinical prediction rule for a specific condition, which of the following is true? A. The tool can be applied to any patient with the condition. B. The tool can determine the clinical probability that a patient has a disease. C. The tool is not necessarily based on evidence. D. The tool uses the receiver operating characteristic curve to statistically model the diagnostic process. A. Use of the tool removes the need for clinical decision making on the part of the clinician. The answer is B. A clinical prediction rule is a statistical model of the diagnostic process. When clinical prediction rules are matched against the opinion of experts, the model usually outperforms the experts because it is applied consistently in each case. However, it is important that clinical prediction rules are used correctly, that is, applied to the patient population that was used to create the rule. Clinical prediction rules force a scientific assessment of the patient's symptoms, signs, and other data to develop a numerical probability of a disease or an outcome. They help clinicians to estimate probability more accurately. A good example of a clinical prediction rule is to estimate pretest probability is the Wells score in suspected deep vein thrombosis. 1.4. Regarding normal values, which of the following statements is true? A. A normal result means that disease is not present. A normal result specific to a particular disease is not found in a person with the disease. C. Normal values do not vary significantly within the same person. D. Normal values follow a Poisson distribution. E. 1 in 20 healthy people will have values that lie outside the reference range. The answer would be E. Most tests provide quantitative results on a continuous numerical scale. In order to classify quantitative results as normal or abnormal, it is necessary to define a cutoff point. Many quantitative measurements in populations have a Gaussian or normal distribution. By convention, the normal reference range is defined as those values that encompass 95% of the population, or two standard deviations above and below the mean. This means that 2.5% of the normal population will have values above and 2.5% will have values below the normal range. In some diseases, there is no overlap between results from the abnormal and normal population. However, in many diseases, there is overlap. So, a healthy person can have an abnormal result and a person with disease can have a normal result. Normal values also vary from day to day in the same person in the absence of a real change because of biological variation and laboratory variation. The extent to which a blood test is allowed to vary before it has truly changed is called the critical difference. 1.5. An 80-year-old man presented with a fall on a background of a 2 week history of his legs giving way and a history of increasing low back pain. In this scenario, which of the following strategies to reduce errors in clinical reasoning would be the most appropriate? A. An assessment of his mobility. B. An X-ray of the lumbar spine. C. Generating a problem representation. D. Use of a clinical prediction rule. E. Using red flags and ROWS rule out worst case scenario. The answer would be E. Various strategies can be used to reduce errors in clinical reasoning, including taking a proper history and performing a thorough physical examination, generating a problem representation, and using mnemonics and checklist. Using red flags and RAWs rule out worst case scenario forces clinicians to think about serious diseases that can present with common symptoms. In this example, it forces clinicians to consider the possibility of cord compression. Red flags and rows helps to avoid cognitive biases such as the framing effect and premature closure.